Hello, my name is Dr. Dewan S. Raja. Today I will discuss about the descending tracts or motor tracts. The descending tracts refers to pathways along which nerve impulses travel from the brain down the spinal cord to communicate with the motor neurons and regulate voluntary movements. There are two main groups of descending tracts, the corticospinal tract and corticobulbar tract in one group, extrapyramidal tract in another group. Corticospinal tract extend from the cerebral cortex to the anterior horns of the spinal cord. Corticobulbar tract, they passes along with corticospinal tract and they end up in the motor cranial nerve nuclei in the brain stem, like the facial nerve, the hypoglossal nerve, oculomotor nerve, or the mandibular nerve. We'll give more emphasis on the corticospinal tract. That is also called pyramidal tract. Location of corticospinal tract, pyramidal tracts. Location, this tract originates in the cerebral cortex, specifically the primary motor cortex located in the precentral gyrus, not necessarily always. Some fiber also come from the postcentral gyrus. Function, they are responsible for precise, skilled, voluntary movement of the distal extremities, such as hand and fingers. Pathway, corticospinal tract descends through the internal capsule, cerebral peduncle, and the medullary pyramids, hence the term pyramidal tract. What are the features of corticospinal tract lesion? Contralateral paresis, slowness of voluntary movement, decrease in strength, positive Babinski sign. So there will be dorsiflexion and fanning out of the toes on eliciting the hammer on the sole of the foot. There will be positive Babinski sign. Okay, here is the corticospinal tract. The axons of pyramidal cells situated in the fifth layer of cerebral cortex. About a third of the fiber originate from the primary motor cortex, area 4. Primary motor cortex is in the precentral gyrus. Another third from the secondary motor cortex, area 6, and final third from the parietal lobe, area 3, 1, 2. Thus, 2/3 of the fiber arise from the precentral gyrus, 1/3 of the fiber arise from the postcentral gyrus. So, cerebral cortex, this is the internal capsule going to the brain stem. This is the cerebral peduncle, the medulla oblongata. Here, fibers crosses, most of the fiber, around 75% fiber, go to the other side. Only 10% fiber remain in the same side. Other side fiber, we call it the lateral corticospinal tract. In the spinal cord, go to the other side. Okay, so we got the posterior limb of internal capsule here, corticospinal tract in the middle 3/5 of the basis peduncle of the midbrain. Okay, then it goes to the pyramid. Here, this is the pyramid. Okay, pyramid of the medulla oblongata. Okay, we got that. There will be deposition of the fiber at the pyramid, lower part of the pyramid. Okay, so we got that this is the midbrain, this is the pons, this is the medulla oblongata. These three parts forms the brain stem. So fiber again, cerebral cortex through the internal capsule, going to the cerebral peduncle, through the pons to the medulla oblongata. Okay, medulla oblongata, and they will be crossing the lower part of medulla oblongata to the other side. Some fiber don't cross, but they eventually cross in the cervical and upper thoracic region. Corticospinal tract, pyramidal tract pathway, the majority of the fiber in the corticospinal tract cross to the opposite side of the spinal cord, and the level of the medulla there will be deposition, forming lateral corticospinal tract, and this tract is longer than that of the anterior spinal thalamic tract. It extends to the entire length of the spinal cord. A smaller portion remains ipsilateral, forming the anterior corticospinal tract, but they also eventually crosses to the other side at the lower end. Clinical significance: damage to the corticospinal tract can result in conditions such as spastic paralysis, where there is increased muscle tone and exaggerated reflexes. Okay, so if you look at that, this is the lateral corticospinal tract here. This is the anterior corticospinal tract. These are motor. We have also some extrapyramidal fiber I am saying here, like vestibulospinal, olivospinal. We may get also like rubrospinal tract. Okay, so these are extrapyramidal tracts. Here, if we go through the corticobulbar tract, what I discussed, they passes along with the corticospinal tract, and they are going to the nuclei of the cranial nerve in the midbrain, in the pons, in the medulla oblongata level, like the vagus nerve nucleus ambiguous. They are contralateral, but they have bilateral connections. In most cases, they're mostly contralateral. Going to the muscles of facial expression here, seventh cranial nerve, abducent nerve, all motor cranial nerves are connected by the corticobulbar tract. They come from the cerebral cortex along with the corticospinal tract. Okay, so we got that. Extrapyramidal tract location. These tracts originate in various subcortical nuclei such as basal ganglia. Okay, that caudate nucleus, lentiform nucleus, putamen, claustrum, and also in the brainstem. Brainstem is also have the red nucleus. You get that. With the tectum, so you get the tectospinal fiber, rubrospinal fiber. Function: they are involved in modulating and regulating motor function. So they make the platform for the fine motor function. They make the stage. They modulate and regulate motor function, including posture, muscle tone, and involuntary movements. Extrapyramidal system influences motor control. They make the platform, basis for the motor function. Extrapyramidal tract pathway. Extrapyramidal tract consists of several pathways, including the rubrospinal tract from the red nucleus to the spinal cord level, tectospinal tract from the tectum of the midbrain to the spinal cord, vestibulospinal tract from the vestibular nucleus to the spinal region, and reticulospinal tract from the reticular area in the upper part of the cervical region and the brainstem to the spinal cord. This tract largely remain ipsilateral, do not decollete, and influence both proximal and distal muscles. Clinical significance: dysfunction of the extrapyramidal tract can lead to the movement disorders such as Parkinson's disease that lead to rigidity, tremor, and poverty of movement, where there is a loss of dopaminergic neuron, because these neurons are formed in the in the substantia nigra of the midbrain. In the substantia nigra, or Huntington disease characterized by degeneration of neuron in the basal nucleus, like basal ganglia, like that of the caudate nucleus. And that's all about the descending tract, pyramidal tract, or corticospinal tract, corticobulbar tract, and that is from the cerebral cortex to the cranial motor cranial nerve nuclei. We have also extrapyramidal fiber that are related to the basal ganglia and subthalamic nuclei. If you have any question, please feel free to ask me. Please share the information with your friends. Please support my channel. Please subscribe me. Have a nice, wonderful, and blessed day. Bye now.